Before we watch Nancy McWilliams demonstrate psychodynamic therapy, I have a few questions that I'd like to ask her about this approach. Nancy, welcome.
Thank you.
Just what is psychodynamic therapy?
It actually is a range of approaches that derive from early work by Sigmund Freud and then his colleagues and then his followers that emphasizes the unconscious source of mental and emotional suffering and the importance of becoming conscious of internal conflict to try to deal with that.
Can you talk some more about the theoretical roots?
Well, Freud was not the first person to discover the unconscious, but he linked it up with a particular kind of suffering that was called hysteria in his time, which now we would more call, I think, post-traumatic phenomena, in which he was very impressed by what they were learning about hypnosis and about unconscious aspects of behavior. And he found that if you encourage, he tried several different things, but if you encouraged people to speak freely about their feelings and thoughts and fantasies, actually it was a patient who taught him that, they would gradually get in contact with less conscious parts of themselves. They would see conflicts that had been unconscious, and they would start being able to solve their problems without developing unfortunate symptoms.
So how would you say this approach is unique among the various therapies?
You know, I think all therapies eventually discover some of the same aspects about human nature, so I'm not sure I can claim total uniqueness for anything about psychoanalysis, but certainly its explicit emphasis on unconscious factors in individuals and going on between two people is a central part of what analysts and psychodynamic therapists think about. And I think in terms of how we work with patients, there's a lot of emphasis on how the past gets reenacted in the present, in the here and now relationship, and that gets kind of deconstructed. And we emphasize also the conflict in people, that they want to get better and that they're afraid to get better. And so they try to get better, but they resist getting better. And we try to help them see the part of themselves that's resisting it and work through that.
Now, are there steps and stages to the work that you do? Kind of a process that you follow?
Only in a very overarching way. I think every therapy is different. I would say one of the strengths of the psychoanalytic tradition has been its attunement to individuality. But in a very general way, the first part of the therapy process involves trying to establish a trusting relationship, a collaborative relationship, one that is asymmetrical, of course, because the client is the one coming for help, but that's mutually collaborative.
Are there unique ways that you would do that in this approach to create that sense of safety, that relationship?
One of the ways would be to keep an eye on what might be in the way of this relationship feeling positive to the patient. Again, a focus on the resisting aspects of the person. If the person's had a bad experience with women, for example, if the mother was, let's say, cruel or negligent, I would be attending very early to demonstrating that there could be a different outcome of a relationship with a woman, with me.
Okay, so you start with this relationship, then what would come next?
And then there's a long or short, depending on the structure of the therapy, period of elaboration of what the client is suffering with an effort to deepen the understanding of that, emotionally as well as intellectually, over a period of time, and seeing how the core problem reenacts itself in various situations, but especially in the therapy relationship. And once there's an agreement between the parties that there's significant progress made, usually people then move toward a termination phase. Although sometimes termination is clear at the beginning if you have a 12-session contract for whatever reason. And there are some patients who I think are essentially lifelong contacts, even though they may not stay in formal therapy. Some people are pretty damaged.
This is a deeper approach in terms of your work. You go deeper inside the individual, and it's a longer term approach?
Well, you know, it started as a very short-term approach. Like, you know, all the psychotherapies tend to start that way.
Right.
They start with claims that they can help people very fast. And Freud did too. He would call it an analysis if you saw him for 6 weeks. But it lengthened as therapists ran into the complexities of people. And because it's the oldest of the contemporary psychotherapies, it's probably the one that does go on the longest. Depth is a kind of a funny metaphor. You know, what do we mean by that? Emotional power, or making deeply unconscious issues conscious? But I think one of the conceits of the psychoanalytic tradition has been that it's deep, and that we go the distance, and that it often takes a long time.
Now, you mentioned in just a moment ago about the clients doing free association, just talking and talking and talking. Are there other techniques or strategies that you use in this approach?
We're more likely to look at dreams than people in other approaches, although there's some exceptions to that. We're more likely to encourage patients to talk about fantasy, and we're more likely to try to make them feel comfortable with the negative aspects of their reactions to us.
Now, this approach has been around for a long time, the psychodynamic or the psychoanalytical approach. Is there a research base that supports its effectiveness?
Yes. I guess the best recent article trying to put a whole lot of meta-analyses together would be Jonathan Shedler's article about the effectiveness of psychodynamic therapy. Hans Strupp found that earlier. It was implicit in Smith, Glass, and Miller. It's implicit in the Consumer Reports study. I have to say, the current paradigm for research is one that doesn't sit easily with a psychoanalytic approach, because the current paradigm really came from very important work by David Barlow to try to make the point that psychotherapeutic interventions are as effective as psychopharmacological ones. And so it came to be common to set up short-term therapies in which you took data at the beginning, you manualized what you did, you took data at the end, and compare them with drug therapies. And I think that's an interesting kind of work, and there have been a lot of studies that they call horse race studies, where you see, well, is this kind of therapy better than this, better than this?
Right.
Using the symptomatic presentation and the sort of evaluation of that at the end. And I think the unintended consequence of that is to buy into a kind of drug company notion of what psychotherapy is about, that it's about just getting rid of observable symptoms, when so often what people come to us for is a kind of sickness of soul that's very complex. And it's not so much about just getting rid of their temporary anxiety. It's about self-knowledge. It's about the interaction of a substance use problem with their anxiety. It's about the interaction of depression with their anxiety. For me, the research literature that is critically supportive of what I do is not necessarily the horse race studies, which tend to come out with what they've called the dodo bird verdict, that all therapies work and all should get prizes. And probably the way they work has much more to do with relationship factors and personality factors than with so-called techniques. But the research on affect, on attachment, on neuroscience, on personality, on defense mechanisms, and we have 30, 40 years of research on that stuff, are very valuable to me and very consistent with my psychoanalytic metaphors and theories.
So it sounds like some of the more recent ways of researching psychotherapy is to simplify the process, and your approach leaves the complex process complex.
Yes, I think that's a really good summary.
Yeah. Now, in a moment, we're going to watch you work with an actual client. And what are you going to look for in the interview? What's going to be important?
I will be trying to feel my way into what kind of relationship starts to develop between me and the person. I'll be attending to not only what they're saying, I'll certainly want to feel what it is they're suffering with that brought them. But I'll want to experience how they're relating to me, not just verbally, but with their facial affect, with their body language, and what gets stirred up in me in response. In other words, their transference to me and my countertransference to them. So I'll be paying attention to subtleties, including a lot of attention to my own internal process, what thoughts are starting to go through my mind, what songs start to go through my mind, what feelings, what body sensations I'm sensing with them. I won't say much about this usually, certainly at the very beginning, but that's how I'm experiencing
the relationship
it.
and monitoring yourself.
Yeah.
Now, are you going to pay attention to the history, the story, the presenting problem, the client's thoughts, their feelings, their behavior?
All of that.
Yeah.
It's kind of a myth that psychoanalysts take a huge amount of attention to just rehashing the client's history. But it is true that the history is very important to us to understand, and to understand with the client, because if the client doesn't understand the reasons that they developed a particular self-defeating pattern or type of suffering, what they're going to do is blame themselves or blame other people, and that's not going to get them anywhere. If they can start seeing that the way that they behave makes sense based on what their situation was as a young person, they can start forgiving themselves, not being so shamed, and in their prefrontal cortex, distinguishing between then and now. So we do spend some time trying to mine history, but we pay a lot of attention to that early so that we can make a formulation in our mind about this patient's troubles. And we also monitor it when we feel the history coming into the here and now relationship. When I feel a client behaving toward me a certain way, I'll start thinking, what in the person's history makes sense of the fact that they're suddenly wary of me or ingratiating toward me or hostile toward me or whatever I'm feeling? How do I understand that in the context of the person's life? Also, I'll be asking, have I done anything to make them wary or hostile or whatever they're feeling toward me?
Now, just like clients have these mistakes they make or these self-destructive ways of dealing with life, what do you want to make sure you don't do in your interview?
That's a good question. I don't want to foreclose exploration. I don't want to close down something. I don't want to assume that I know what the patient means when the patient says something. I want to help the patient continue to elaborate their experience, their story. They may have had an experience that I think is very much like an experience of mine. But I'll try to hear whether they may have experienced that differently.
Mhm.
So I try very hard not to cover something over, close something up, collude with the part of themselves that doesn't want to go to a place that's really painful.
Right, okay. So you try to be with the person rather than put a label on what's going on, or to try to categorize it and
Yeah,
understand it in their terms.
and I guess I try to pay attention to my own
Okay.
narcissism, because patients often tell
Yeah.
you how much you're helping them,
And that can be hard to...
and a part of you wants to say, yeah, I'm great,
Good observation.
rather than
Yeah.
to say, well, what about the part of you that doesn't feel helped? Or do you have
Right.
any negative feelings coexisting with these grateful ones?
So what makes a good patient or client for your type of therapy?
Somebody who's curious about themselves, who's not too concrete. You know, some people really want a program, and that's not the strength of the psychoanalytic method. Although, you know, if you understand a person well enough, you can adapt to that need. But somebody who is curious, motivated to understand themselves, not afraid of attachment, or able to tolerate their fear of attachment and closeness, because a psychoanalytic therapist is going to get to see, if the process goes right, the ugly parts of the self, the needy parts of the self, the parts of the self that the person has a lot of shame about.
As a kind of a final question that might pull all of our interview together, what are the ingredients of effective therapy? I mean, what's going to make this work when you see clients?
Well, all the research literature, I mean, as it's been summarized by people like Bruce Wampold or Sidney Blatt, Stanley Messer, many other people actually, seems to suggest the conclusion that what's therapeutic is not a particular technique. The relationship is what's therapeutic. The person gets a different experience. They come in, they expect an old story, and somehow a good therapist makes that story come out differently from the way they thought it had to come out. And I think you can do that from any theoretical perspective, and I've always been impressed with the empirical literature showing that experienced therapists have much more in common than experienced therapists have with novices in their own orientation. So I think we learn over time to give ourselves over to a process that's kind of organic, and trust that it's going to go someplace. If we watch it and try to get in the way of it reenacting point for point all the bad stuff in the person's history, we can make it come out differently. We'll be a partner in this project.
Well, thank you so much for your comments, and let's move on now to see psychodynamic therapy in action.
Okay.